Oh, hello, everyone. Welcome to Mom's Corner. I hope everyone's doing well today. My name is Zainab, your host. I'm so excited to be here with you today. I want to thank everyone for joining us. Before we proceed, I would like to remind everyone, as I put in the chat box, that I will share the link to the stipend form shortly during our meeting. For those who are regulars on Mom's Corner, thank you for being here. And for those who are joining us for the first time, welcome and thank you. And a big thank you to our amazing doctors for being here with us today as well at a different time. Mom's Corner is one of the many programs under the umbrella of Global Perinatal Services, or GPS. And GPS is a nonprofit organization doing amazing work and changing lives every day. Our mission is to provide community-based doula services that refugee and immigrant women and their families during pregnancy, birth, and into early parenting. Mom's Corner is a space not just for moms, but for all women folk, because at GPS, we believe that motherhood is an extension of a woman's identity and not the definition. Mom's Corner, since the pandemic, has become not just a space where we come to find empathy, support, and camaraderie, but a safe haven and access to so many critical resources in our communities. And about today's topic, mental health in preteens and teenagers, I wanted to preface our conversation today by acknowledging that the topic of mental illness can be uncomfortable for many of us because of the stigma around it. The stigma of how mental illness is perceived in our families, communities, and society. And some think that if we don't talk about it, then it won't come into existence. And so we turn a blind eye and pretend that it will resolve on its own in time. And when it comes to mental illness in children and teenagers, we wait for months and months in seeking treatment until those symptoms are exacerbated. So it is my hope today that today's session helps us become a little more vulnerable and comfortable in talking about mental illness in children and teenagers. And ourselves as well, and gives us a permission to ask any and all questions we often don't ask in this judgment-free, empathetic, and expert-driven and evidence-based space. And so I encourage, if you have any questions, please raise your hand, or you can drop it in the chat box or send it to me privately, and we can ask. And and our doctors will be more than happy to answer, I'm sure. And so without further ado, I will give the floor to you, doctors. Thank you.
Thank you so much. Like it says on the presentation, my name is Blake Henley.
And I'm Freshta Engel.
And Freshta and I are in the reproductive justice area of concentration within the Swedish family medicine residency group. So our big goals outside of working many, many hours in the hospital are to champion our community towards maintaining personal bodily autonomy, having children, not having children, and parenting children in safe and sustainable communities. So this partnership has been a lovely part of our program for now many years. And so we're happy to be continuing here with our monthly Mom's Corner presentations. As was discussed, we will be talking about mental health. It's really in adolescence, so anywhere from the studies we evaluated are from age 8 up to age 18 and sometimes 20. I do want to include a trigger warning here that we have a lot of, we talk about suicide quite a bit, about incidents, warning signs, and preventative methods. So I just want to make sure that those that will be too triggering for have the opportunity to respectfully log off at this point. I also want to add in that as someone who created some of these slides, I do have a bias as someone who is raised in a predominantly white community with a white family, with many doctors in my family. So I did have a lot of exposure to mental health conversations. And I am very familiar that that is not as common in other cultures and communities. All that being said, I did have a sister who committed suicide when she was a teenager. So I also feel like I have a very intimate relationship with this topic. So moving forward, the kind of why this is something that matters to us and hopefully matters to the community at large is that 1 in 5 teens will suffer from at least one mental health disorder, and half of them do not receive care that they need. And that number is even lower in BIPOC communities. So to start with our outline today, how we fit such a big conversation topic into 1 hour was really difficult, really overwhelming. So we're just going to graze the surface of a few things. Our goal is really to discuss the common mental health disorders in adolescents. We're only touching on 3 because they are the most common, but please note that there are many, many more that adolescents could suffer from. And then we really wanted to highlight some things that adults could do to help, whether it's your children, your nieces, your nephews, or just other young people within your community, and highlight at the very end just a few local community resources. We also wanted to sprinkle throughout here some BIPOC statistics about how there is a disparity when it comes to mental health, especially within our young adults and adolescents. And so we have some statistics to share there that only highlight areas of discrepancy that you all are probably already aware of. And I will say that we're having this conversation sort of from a very basic level of mental health disorders and diagnoses. And so I really apologize if any of it seems too basic. Our goal is just to meet everybody at this sort of basic level and build up together. So with that, I'll hand it off to Dr. Engel, who is going to start with the mental health disorders in teens.
So thank you, Blake. So as Blake said, we are going to only touch on the 3 most common diagnoses. Those include depression, suicidal ideation, and anxiety. So I'll start off by just giving a little bit of stats for each of these topics. And so as you can see, for depression, the prevalence kind of increases and hits its peak at the 12 to 17 range, which makes sense. This is the time where people and teenagers are going through a lot of discovery, bodily changes, that kind of stuff. And depression can be really common in these populations. As for diagnosis, this is not saying that you as the parent need to be the person making this diagnosis, but sometimes it could be helpful to have an idea of what symptoms go along with the diagnosis of depression. And this can help your doctor by you answering some of the questions that they have and not being surprised by some of the questions that they have. And so some of the symptoms of depression include depressed or irritable mood, decreased interest or pleasure in doing things that they would previously really enjoy, change in appetite and or weight loss and weight gain, sleep changes that can be sleeping less or sleeping more, psychomotor agitation. This can be repetitive things like pacing, hand wringing, nail biting, that kind of stuff. Fatigue, feeling worthless, inability to concentrate, and even thoughts of suicide. And along with this diagnosis, so these symptoms can come in people that don't have the diagnosis of depression. You do need at least 5 of these to meet criteria for depression. And along with the 5 symptoms, you also need to have some sort of functional impairment. So that means that you're having the kiddos having trouble in school, having trouble with relationships, having trouble meeting or hitting responsibilities that they previously were able to do. And just a note, this depression as a diagnosis can be something that it could be one diagnosis that someone has, but also another diagnosis is common in about 60% of people that have depression. So once you have the diagnosis of depression, it can be helpful to talk about or think about other diagnoses of mental health that come along with it. So I just put in a little screenshot of a screening tool that your doctor will use during a well child check kind of every year. It starts at the age of 12, 13 and goes up until 18. And after the age of 18, it's a yearly screening as well. And so this screener, I mean, it's small. We don't have to read through it all, but it's a little bit different for adults versus adolescents in that it has a few more questions that are simplified and can be easier for kiddos to answer. And basically they answer the questions and you add up the score that they get, and it puts them in a criteria of mild to moderate, severe. It changes the kind of category of depression that they might have. And so then that can give us an idea of what we can do to help manage it. So just to talk about some risk factors, the risk factors for depression and suicidal ideation as well as anxiety are very similar, but I'll just go through them. So the one of the risk factors for depression is if you have a family history of depression. So if a family member has already had a diagnosis, or you suspect that they had a diagnosis that maybe wasn't formally diagnosed, this can put kiddos at more of a risk of having it. Family dysfunction or conflict can put them at increased risk. Some psychosocial stressors, this can include things like bullying at school or financial difficulties at home. And then other mental health diagnoses that I talked about earlier can put you at risk for depression as well. And substance use can also put you at risk for depression. So the management of depression is twofold. The first thing that we always try in any person that has a diagnosis of depression is therapy. And this isn't necessarily like you do it a couple of times and see if it works for you. It's more of a you diligently do it for about 8 weeks with a therapist that you trust. And sometimes towards the beginning when things are worse, you may need more sessions during the week. So it can be 3-4 times a week. And then once that, and you kind of see how the first couple of weeks go. If your child is not really noticing a change or response with therapy, this is the time where medication can sometimes be helpful. So if they've given a good try with therapy and it hasn't been helpful, then a medication can be something you talk about with your doctor. And I would be amiss if I didn't mention this, but medications for depression have no role in emergency situations. They can take about 2 to 4 weeks to become effective. And so if your child is experiencing things like suicide, which I'll talk about in a little bit, medication has no role in treating that. The mainstay is keeping them safe, which we'll talk about a little bit later, and also having a trained and trusted therapist on their side as well. And so here's our first of a few statistics throughout this presentation, just saying what we already know, but putting a number to it. That Black and Latinx children are about 14% less likely than white youth to receive treatment for their depression. So next I talk about, go ahead.
Engel. Yeah, you got cut off. I'm not sure if I'm the only one, if other people heard you okay. Just want to make sure.
Which part?
Just the last part of the last slide. Were you guys hearing my end?
I heard you, Freshta, but it
it.
might have been, I heard you, Freshta, but it might have been some of the computer, so I'll go back.
Okay, so this is one of our statistics that we've included throughout the presentation to talk about BIPOC populations. So Black and Latinx children are about 14% less likely than white youth to receive treatment for their depression. So next we'll talk about suicidal ideation. As Dr. Henley mentioned before, if this is a trigger for you, you may leave and we will not be offended or anything like that. You do what's best for you. But suicidal ideation in 2011 was in about 13% of adolescents, there was an attempt for suicide in the previous year that the study was collected, and 8% of them actually attempted it. So planning versus attempting, there's a higher population of people that planned it, and 8% of that 13% actually attempted it. And then suicide is the second leading cause of death among adolescents aged 15 through 19. So some of the things that you as parents should look out for, some of the things that we can help, some of them we can't help, but risk factors and warning signs you should look for are if they have a mental health diagnosis, whether that's depression, whether that's anxiety, whether that's substance use, make sure that you're keeping an eye out for things that I'll talk about a little bit later that people may say that are a trigger for they might be wanting to hurt themselves. Previous suicide attempts also put you at risk for future suicide attempts. People that identify as LGBTQ populations, they have a higher risk of suicidal ideation as well. History of physical or emotional abuse, and family history of suicidal ideation as well. So screening for suicidal ideation is very similar to depression. And so We usually screen adolescents age 12 through 18 every year. Their well child exams for both suicide and depression. The screening tool that I showed you in a few screenshots before for depression also screens for suicide. And sometimes it's helpful to ask a few more questions about a few more specific questions like have you ever wished that you were dead? Have you ever felt that your family was better off without you? Those kind of questions that really get to really have the adolescent kind of answer those questions about suicide and suicide risk. The next stat I have in here for you for that we have sprinkled in throughout the presentation is that in 2018, a study found that the suicide rate in Black children was nearly twice that of white children at the same age. So the management of suicidal ideation is it's definitely really complicated, and it really helps us to understand how often the kiddo is having these thoughts. Like, are you having them every day? What plans do you have in place? Do you have what is the level of intent? Are you going to do it today, or is it just kind of a fleeting thought that you have? And just keeping an eye on stressors, social support, substance use history, and substance use history specifically because it can increase your risk of impulsivity. And so that can increase chances of suicidal ideation as well. So once you have decided that your kiddo or somebody that you know has suicidal ideation, it's important to have a next step and some plans in place. So if this person has some passive suicidal ideation, meaning that they have some fleeting thoughts but don't have a solidified plan, therapy, possibly a medication, and really close follow-up with a trusted PCP is helpful and important. If the person has active suicidal ideation, that is an emergency. That means that we need to seek medical help right away, and that is usually through the emergency department, although sometimes the PCP can help with placement of certain things as well. And one thing that a PCP or somebody in the emergency department can do to help people before, sending, if it's safe to send them home, is create something called a safety plan. So a safety plan basically is kind of helping assess with the kiddo as well as the parent what the warning signs are for this particular person. Is it a certain situation? Is it a certain kind of behavior? Is it being in a certain space? And then removing lethal agents from the area. And so we'll talk a little bit about this later, but making sure that you have an idea of what's at home that could possibly help or harm a person, like firearms, poisons, medicines, that kind of stuff. And then kind of thinking about what the person really lives for, like what really motivates the person to be happy and continue living life. And that can be a person, it could be a place, it can be activities. And so these kind of things all together can help the person that has been recently diagnosed with suicidal ideation um, really be safe if they do decide to, if it is safe for them to go home. And having a plan for how they will contact a medical professional, therapist, crisis line, that kind of thing is also something that your PCP can help with, and also something that you can help with as well. So next we will talk about generalized anxiety. This is the most common mental health diagnosis in adolescents. As you can see, the stats are really high. It's about 1/3 of people aged 13 through 17 have the diagnosis of generalized anxiety. And so the how to actually diagnose this is complicated. And like I said, you don't have to do this, but it involves excessive anxiety and worrying for more days than not over the last 6 months and about multiple things. So it's not necessarily like them worrying about a college exam. It's about all aspects or most aspects of their life. And in addition to having that anxiety and worry, it's difficult for them to control those feelings. And they have another symptom like restlessness, they're easily fatigued, they have trouble concentrating, and all of this affects their schooling or their activity that they previously really enjoyed. Um, Another important factor is that we need to make sure that these symptoms are not related to another substance, whether it's medication or an illicit substance. Medications that can cause some anxiety symptoms include ADHD medications that can be uppers and cause a little bit of the restlessness and that kind of stuff. And so making sure that we've ruled out all other causes of the symptoms that the person is having. Some risk factors, like I said before, the risk factors for a lot of these are similar, but family history of anxiety, family dysfunction or conflict, psychosocial stressors like bullying, and like I said, substance use or another mental health diagnosis. For anxiety, we recommend screening a little bit younger for anxiety than for depression. So the recommended age is 8 to 18. And the preferred screening method we actually use is called the SCARED. And I have a screenshot of it on the next slide. So the SCARED is a 5-question thing about how just about some of the symptoms of anxiety, and if there are 3 or more of these present, we go to a really long thing that I didn't want to screenshot and put on here about what, and it helps kind of differentiate the type of anxiety that the person is feeling and kind of how severe it is. So the management for anxiety, generalizing the anxiety is pretty similar to depression in that for mild to moderate anxiety, therapy alone is first line, and it is the best thing that we can do for them. For severe anxiety, there are some studies that say medication and therapy can be helpful. And the one situation where most people agree that medication is helpful is if a person has the diagnosis of depression and anxiety at the same time. So the medication that we use to treat both of these are the same. And so if they have both of these things and it's really affecting their schooling and that kind of stuff, this would be a time that medication we just start with in addition to therapy.
So now we're going to move on to the second part of the presentation. Now that Freshta has given you all a really great foundation of what mental health disorders are in the top 3 within adolescents and teens, I want to try to give some ideas of what adults in the community can do to help these teenagers. I know it can feel really overwhelming to see all of these different diagnoses and know that the prevalence of these are increasing. So in all of the different generations in the past, this is the most prevalent mental health disorders have been diagnosed. And it does seem like it's the most prevalent that they've also been around. Granted, our diagnosis has gotten better, but there are a lot of social and community stressors that our youths are dealing with right now, as you can imagine, with the pandemic and politics and everything else. So on that topic, sorry to go back, I have 3 sort of buckets that I think adults should think about in their mind when they think about helping these teenagers. So the first one is to learn, and that is you're already here, you're already doing part of that, is to get a really good idea about what the risks and what you're looking for in your youth. Particularly, I think mental health disorders seem black and white or at least medical professionals like to keep them black and white, but in reality, it is a very complicated spectrum of symptoms. And so at any point, if you're feeling unsure or unclear, asking for help and educating both yourself and your community a bit more on what could be going on. I think there's a parental instinct to protect our children, and I have certain ways to protect in a different way. You know, we're used to helping our children we're protecting our children at the gym or the jungle gym from falling down, and it's a little bit less physical and more emotional help that we can do to protect our children as they enter into this young adulthood. And then lastly, I just have a brief little bit of getting help, and that's potentially one of the biggest things you can do if you as the parent are struggling with next steps as well. So when it comes to learning, I'm not going to belabor the mental health disorders that Dr. Engel already went into in depth. I just want to say that there are many above the three that we talked about. Those are the three biggest ones that teens are dealing with, especially since the pandemic. So these statistics are from a poll in 2021 about an increase in these that families have noticed in their teens. So this isn't prevalence. This isn't how many teen boys in the population, but this is how many have increased. So this just shows that the pandemic alone has had a really significant impact on our teenagers. We've seen this in the clinic, especially, so I can say anecdotally, it just seems like we were getting a lot more mental health concerns and complaints from both parents and children. So this is just data to back up that anecdotal experience. So now that you've done some of that learning, next step is protecting. So when I think of protecting teens, I think of this multi-phase sphere around them. So I think of the teenager themselves and what we can do to protect them at an individual level. I think of the family level. I think of the home, the physical home they're in, and then I think of the community. So starting at the individual level, we know, again, since we're in Western medicine, we're very evidence-based. So everything that we talk about and present on has research to back it up. I say that because sometimes there's research, there's always research that's yet to be done. So this is not hard and fast, but this is what we know now. We know that these risk factors listed here are elements that can contribute to some sort of mental can be risk factors that could increase an individual's risk to developing a mental health disorder in their teen years. So interestingly, female gender and early puberty are two that are out of our control. The rest are things that we can start working on fostering. So anything like low self-esteem, poor social skills, emotional problems in childhood, early substance use, head injuries, interestingly, or childhood exposure to lead or mercury. Those are all individual risk factors that can increase a child's risk. Protective factors are essentially the opposite. So positive physical development. This is essentially exercise and moving the body and building strength. Academic achievement or intellectual development. They don't need to be getting straight A's in school, but as long as they're feeling that their intellect is developing and being challenged, that has a protective factor against future mental health. High self-esteem, emotional self-regulation, which also involves coping skills and problem-solving skills. And then what I thought was interesting is the data suggests that engagement and connections in at least two of the following spheres, which is school, with their peers, in athletics, employment, religion, or culture, is also protective. So it gives us a lot of different options on how we can try to get our youth and our teens sort of protected in a bubble of their kind of individual standpoints. Moving on to within the family, Dr. Engel also highlighted some of these, so I will move a bit quickly. Risk factors are parental depression or anxiety. And I want to highlight that the study was focusing on parental depression or anxiety that has been untreated or unmanaged. It can actually be protective for youth to see their parents modeling healthy treatment strategies for mental health disorders. Parent-child conflict is a risk factor, a negative family environment. So that can include things like parental fighting or interfamilial discord. Any child abuse or maltreatment is a significant increase in the risk of developing a mental health disorder, parental drug and alcohol use, and parental unemployment. And so kind of the opposite end of that, things that protect our children are structure, limits, rules, monitoring, and predictability. I highlight this one especially because especially in the pandemic, we were getting a lot, there was a really hard balance between screen time, so how often youth could be on their screen. For their general vision, the recommendation is 2 or fewer hours. If you've heard doctors talk about it, our recommendation is technically less than 1 hour. And the main reason for that is the repetitive behavior and the socially isolating experience of that screen time can be actually very detrimental to their mental health, which feels counterintuitive because we think social media is a chance to be connected socially with your peers. I could talk for another hour about the damages of social media to self-esteem, but we're seeing that actually play out in data as well. And that is one of the predicted reasons why this current generation of teenagers is at highest risk for mental health disorders compared to other generations, because of the exposures they have that are so much greater than any previous generation. So if you haven't already, I always recommend establishing some sort of boundaries with your teens and youth about screen time, particularly on their phone or tablet. That's things like going on social media, things like texting is usually okay because that is a bit more social, but things like social media, things like video games, I recommend pretty strong boundaries, and 1 to 2 hours is my recommendation at most. And I think I have told many teenagers in my clinic, and most average over 9 to 10 hours on their phone, including during school time. So those numbers are obviously very misaligned, but trying to get them as close as possible is going to be the best thing for their mental health moving forward. Supportive relationships with family members is actually a really key protection as well. And this is especially true with siblings. And then lastly, that clear expectations for behavior and values, you know, to protect your child with mental health, to always provide that supportive listening and supportive structure without being too lenient on some of the boundaries that help them really feel protected and feel that they have the freedom without having overwhelm of space. And kind of within the family brings me to the physical within the home. In particular, things that teens and adolescents can use to harm themselves, either temporarily or permanently, just have to be managed. This is the same as when a kid starts to walk, how you hopefully cover some corners. There's just a new type of corner now. So things like medicines, drugs, and alcohol, those need to be in a completely separate space, locked up, not just out of reach high. I will say I work with adolescents all the time, and they are so creative and clever when it comes to getting their hands on something they want. So I recommend a locked box. And toxic chemicals, anything like bleach, cleaning products, yard products, pest poisons, those are a bigger concern for our youth, but they're also our children under 8, but they're also a big concern for anyone who is at risk for hurting themselves. And who might not know the sort of end result of consuming those products. And then lastly, sharps, and this is knives and razors. If you have any child who's at risk, it's best to just have these out of the house entirely. This gets me to my next point. So I will just say a disclaimer that this is not a political statement. This is not I am not in a political debate right now. We have data that says that most teens and preteens who die by suicide use a firearm to do so. And because of that, this is one of the biggest risk factors is having a gun in the home or in the home of a relative or friend. So I'm very firm with my families about firearm safety. I'm not here to debate whether or not you should have a gun or not, or legally, or what your protections are, but for the protection of your child, I have a very firm line on what we should be doing to protect them from firearms. I do want to say that because the reason that firearm suicides are so prevalent is because, you know, suicidal ideation or attempts are usually very temporary. It's usually a brief experience that a teen or young person is having. They are also at an age where they're incredibly impulsive. But you combine that with the permanency and fast-acting element of a firearm, and we have a very lethal combination that has and will continue to take children's lives. So when it comes, if you do have a firearm in your house, they need to be unloaded. They need to be locked in a lockbox, and the ammunition should be stored separately. The only time I have ever been okay with a gun being in a house is if there are 2 lockboxes, one with ammunition, one with a firearm, and there are 2 different codes. It is much more likely statistically that you will have a child who is considering hurting themselves and you will have an intruder into your house. So I just want everyone to keep that statistic in mind. Using locks is very important. And like I said, combination locks instead of keyed locks. I have heard adolescents tell me that they have found the keys. Their parents don't know they know where the keys are, but when they would like to use them, they know how to do it. And then lastly, like I was talking about previously, if you have any family member who is depressed, suicidal, abusing drugs, you just need to remove the firearms entirely from the house. It's just a safer option for them. And always talk to your kids about firearms risks, just like you would alcohol and drugs. And that's my spiel about firearms. Lastly, the sort of outer sphere that encompasses our youth and young adults is the community at large. So when we're looking at communities, a few risk factors came up that increase the suicide prevalence within communities, and that is community level stressful traumatic events. This includes things like violence and shootings or robberies or closing of major community staples and foundations. poverty, a low community commitment to school. So communities that are more engaged within their school actually have a lower incidence of suicide within that community. And then having significant use of alcohol and drug use and norms that favor that. So we see that communities that are very advocating for alcohol use at things like barbecues and tailgates actually have increased risk of suicide. And urban settings, interestingly, that we think that has to do with a lot of other socioeconomic elements of health. Protective factors, the big thing is presence of mentors, and that is anything from an assigned mentor towards the like big brother, big sister who's, you know, a senior in high school or going to college. That's all really important for you to be seeing and engaging with. Having school and community events, having those more positive norms that lean away from drugs and alcohol. And similarly to protection within the home, clear expectations for behaviors and boundaries actually help teens maintain their safety even more so. And then if you remember, the 3 things I was recommending adults do was learn, protect, and then get help. So I think this is one of the smartest things you can do, and the smartest thing any of us can do is if we're not sure about a certain area or question, the best thing we can do is ask for help. So there are several different areas that I think are the most kind of bang for your buck. I think leaning into your doctor, this could be your pediatrician, your primary care provider, even your adult physician, because they should have the capacity to connect you with all of these other resources. So a behavioral health specialist is the counselors that Dr. Engel was talking about. And your child doesn't have to have a diagnosis of a mental health disorder. Like I said, it is a spectrum. So you can lean into them to rely on their expertise when it comes to diagnosing and having these conversations and learning more. One thing that we all might be familiar with is that teenagers do not like to talk to their parents about a lot of the hard things that are going on with them. Sometimes building that alliance with a behavioral health specialist is an outlet for them to have those conversations in a safe setting, with the understanding that any of these groups that are mentioned here, if they have any concern at all for your child's immediate safety, well-being, or think that they will hurt themselves, they will get you involved and they will get medical professionals involved. So it's a very safe place, and you know it's safe because these are professionals that know the warning signs for things like self-harm and suicide. Social workers and support groups are other really great avenues, both for connecting you with more resources and finding the community elements that might give both the families and their teams extra support. And this we've talked about quite a bit, but if you believe that your child presents a danger to themselves or others, take them to the closest emergency department. Dr. Engel and I work in a hospital, in Swedish Freshta Hospital, and we manage things like this on a regular basis. It is what our world is now, and I am very, very glad a lot of these kids are coming into the hospital. I would rather have that time and time again. And once you're in the hospital, that is going to be the fastest route getting any additional support. So we can get a behavioral counselor to come to the patient's bedside in the hospital within 6 hours, or we can get a social worker involved and get you set up with a support group within 12 hours. So that is where, if things are emergent, without a doubt, you should take your child to get that extra help and support and keep them safe. And then I wanted to emphasize some resources. So for more information, if you just have some extra questions about mental health disorders and a lot of the other ones, like I said, there are hundreds of mental health disorders out there in the world, and it is quite a spectrum. I really love the Seattle Children's Psychiatry and Behavioral Health Program. They have amazing resources online. And you can just Google this. These are also links if we share this slide eventually. If you want to contact an adolescent psychologist or psychiatrist, one good route is to talk to your doctor, and they can help set you up with their recommendations. Another option is the Washington Partnership Access Line. I tell my parents who are worried about their teens to just put this number in their phone. And on weekdays during business hours, it will connect you directly with a psychiatrist, so you can ask any questions and potentially get set up with future appointments. And when it is not a weekday during business hours, you'll be connected to an after hours line where they will connect you with someone the next business day. And then lastly, for an emergency, call 911. If you have a suicide concern, call the Suicide Prevention Hotline. This is now 988. And then there are crisis connections. This is an emergency services. These 3 I put into the teenagers' phones that I see. I make sure they have access to all of them. And there's a crisis connections app that a teenager can text off of their phone in the app, and they're connected with a professional who can help walk them through some hard emotional experiences they might be having. And we're finding that texting tends to work better with teenagers anyway. So these are some sources that we use to source this presentation. There are particularly a lot of data-driven research on adolescent and teenage health and well-being when it comes to mental health disorders. And with that, with about 15 minutes to spare, we just want to say thank you. And thank you, as always, for letting us come here once a month and exploring these topics with you all. And we'd like to open it up for any questions you all might have.
There's a question in the chat from Taylor. So there are a few questions in the chat that I answered, but I'll read this out loud from Taylor, just because the answer is going to be longer than I can type out. So Taylor's question is, instead of taking medications for depression and anxiety for young adults, are there more natural, less addictive things they can do / take that could help with these problems? So many side effects to a lot of these medications. I'm happy to start, and then Blake, you can add whatever you see fit. Super good question. And like I kind of said earlier, the first line treatment for anxiety and depression is definitely therapy, but also, yes, that medications can have a lot of side effects. We can't hide that from you. And as your doctor, we will talk about all of the different side effects with you before we even get into prescribing them. For other things, there isn't like a natural medication that I know of that can help, but there's things like exercise, improve sleep, decrease screen time, and all of those kind of things that like we can work on together to help decrease the effects of depression. And just kind of more like one-on-one open communication can also be helpful. And so I don't know if Dr. Henley, if you have an idea of something that's like natural that can help with depression, but yeah, just like all together, just improving lifestyle and that kind of stuff can definitely help with the effects of depression and anxiety.
Yeah, I totally agree with Dr. Engel. The couple additions I'll say is vitamin D is one of the biggest things we recommend, especially in Seattle, because of how little vitamin D we get from sunshine. Especially in the winter months, I usually have all of my patients on some sort of vitamin D supplementation, and we know low vitamin D can contribute to seasonal affective disorder, which disproportionately affects teenagers as well. So that's one of the more herbal supplements I'll recommend. I always will lean into naturopathic medicine, although I will say that's not my specialty. So I recommend going to a naturopath to see specifically for your teenager what would be most beneficial. Other things that are not something to consume but have a lot of data behind them, one of the biggest ones is mindfulness, and that is mindfulness is an umbrella term for things like meditation and prayer. And that is some of the strongest data. I find it really hard in my 20 minutes with teenagers to counsel them on how to meditate. And I think there are some really helpful apps, like Headspace has a great one, and they have a like teen focused one, and it's free. If you feel like your teenager would benefit from that, it is kind of a personality space if they're open to that sort of sitting there and working on mindfulness. And it's similar to any other treatment, that it doesn't work unless you do. So kids have to be really diligent about it. But that is one of the most effective methods that is non-pharmacological, meaning you don't take a pill for it, for both adolescents, teens, and adults. And exercise. That's another big one. And I love this addition, that journaling on what you're grateful for or the list of goals. I think that is absolutely wonderful. And that's actually another example of mindfulness and focusing on sort of that space of gratitude rather than the negative thinking. It also is really valuable for our teams to model and help them build the habit of positive thinking and positive, that kind of more positive perspective in their life. And that can be a protective factor as well towards future developing mental health. I also need to put in the caveat here that you can do all of this and your child can still develop a mental health disorder. There is an element of socioeconomic status, there is an element of what they're exposed to, and there is a true element of genetics, and there is some that we do not have control over. So my big emphasis to parents when I have teens come in, that this is not a failure in any way, shape, or form, but there are things that we can do to protect our teens who are also dealing with it. So I want to be clear that for some kids, journaling won't be enough, and that's okay.
Thank you for that presentation, doctors. Sorry, I keep having technical issues for some reason. Are there any other questions in the chat box? It won't let me see. It's like back in. Okay. Yeah, I was, is that one working? Okay, I think the other one is in, I'll answer that question. I was wondering, doctors, for a patient like your young patients who are hesitant and they are patients of color, how do you like approach the topic of mental illness with them or the family, or even how to get help?
Totally. And it kind of depends on where they are right now. So like if it's myself alone with the person that has these questions, I just start out broad and I kind of ask them what they're worried about, what they already know about the certain mental health diagnosis, if anybody in the family has it, just to kind of better understand where they're coming from. And then what their worries are with a certain diagnosis, like if they're worried about the stigma associated with it, if they're worried about their parents finding out and that kind of stuff. All of those things, just to kind of better understand the person that's in front of you, can be really helpful. And if the parents in the room and they don't feel comfortable talking about it in front of their parents, that can be definitely a time where we can either have the parents step out for a little bit, or even just talk one-on-one with the patient, and then be like, at the end, if you're concerned about anything, just be like, is it okay if I talk to your parents about this, and that kind of stuff. Just creating a safe space overall can be really helpful with these certain things.
And I know that in some instances, like the parents or caregivers are asked to step out. Is there an age limit to that?
So we usually start it kind of in the adolescent years, like 13, 14 is when a lot of clinics start. And at that time, this isn't a situation where it's like we need to keep all of these secrets from the parents. It's more of like I want you to be open with me as your doctor. And if there are things that the doctor is concerned about, we do have to tell the parent. Like if we're concerned that they're going to harm themselves or harm somebody else, we do have to disclose that to the patient. And I usually start out by saying that. And I'm like, there are only a few reasons I would tell your parents about this, and it's this. And so it's not necessarily to keep it a secret from the parents, but it's more of like getting the kiddo to open up if they can't necessarily open up with their parents around, with the caveat in mind that we do have to tell the parents if there is a risk of harm to themselves or somebody else.
Yeah. Is there something like, how do you interact with the parents about, like, because like I mentioned, and as you know, not a lot of families talk about mental illness. How do you approach that topic with the parents and know that they actually, there's a takeaway from the conversation and not just nodding and saying, okay. Yeah.
You want to take this one, Dr. Henley?
Yeah, good question. We, beyond mental health, that is something we always have to check in on, is how much our patients are actually hearing about our conversation. So I always open it up for any questions, and I usually try to get some sense of their understanding by asking them to tell me what they've heard. And depending on the severity of the situation, I sometimes do have to make some of these facts that we've shared today actually very clear, not only to remove some of the stigma by sharing how prevalent a lot of these things are, but to share how high a risk this specific population is to actually hurting themselves or other people. And I find I've never had a family that isn't appropriately worried and responsive. So I actually remember an incident where I had a man who had a lot of firearms in the house, and his son had told me confidentially that he knew where they were and he knew how to use them if he needed to. And I told the dad that, and within 3 hours, there were no guns in the house left anymore. So I'd say more often than not, I am humbled and inspired by the parents' reaction when I am open and honest about the true risk to their child's life.
Thank you.
And I do, before we move on, I do want to address Rama's question in the chat.
Yeah.
Rama said, what are the steps families can take for patients who are above the age of 18? And how can they get help in getting them the help they need, especially if they are a danger to themselves and others? And a big worry is how Black men are treated within hospital settings, which can prevent many families from seeking help rather than deal with this situation. And I think that is, we know that that is a situation that happens in hospitals. We know that people of color, especially Black men, have poor outcomes in the hospital system. My hope is that by the medical community knowing that and finally voicing that and facing that, we're making the changes that are needed within our system. That's going to take several years. In the meantime, what I always recommend, the emergency room is always a place that you should be able to go and to take your loved ones if you have any concern. I always recommend from the beginning, whether my patients are of any ethnicity, that you make it really clear that you're in a behavioral health crisis or that your loved one is in a behavioral health crisis. We cannot take calls and give you updates on your family if they're in the hospital, unless it's an adolescent. But over the 18, obviously there's patient confidentiality. If you're calling and you say, I'm really worried, I want to know what's happening to my brother, we can't give you that information over the phone. If you call and say, I want you to know my brother is having an acute mental illness concern right now, that can actually be really helpful for the team to know. The big problem in the emergency department is that they do get a lot of people who are using different drugs than alcohol. And while that is still a mental health disorder, they have a lot more of a safety concern for their staff around that. But if we make it really clear, and again, there's obviously racism at play when they are profiling who they think is drunk or high, and that's a system issue that needs to be worked out. In the meantime, making it really clear that may or may not be involved, but there's a mental health problem here. And that is the same as any other acute illness. That is the same as a stroke and a heart attack, and medical professionals need to be treating it as such. And if you ever have an experience to the contrary, I highly, highly recommend you report that to the board of medical professionals, because that is unacceptable.
Yeah. Doctors, could you speak to like what ethnic group is more prone to depression or anxiety that you noticed in your practice? Just curious about that.
Yeah, I can speak to this a bit, Dr. Engel. It's sort of a bias about the patients we see. So we have a really strong Ethiopian and Somalian community. However, I do find, because of some of the mental health stigma, it's a little bit harder to get to those diagnoses. What we do know is that there are no genetic predispositions within different ethnic groups that actually contribute to mental health disorders. So there's nothing genetically outside of like familial genetics, but we can't find any specific genetic pool in different ethnicities that contributes at all. But we do know there are contributions of socioeconomic status, poverty, and race experiences of racism.
Yes, absolutely. Thank you.
And we know that white people are more quickly to be diagnosed and more quickly to be treated. So there is a huge gap there in the healthcare that we need to be providing.
Absolutely. I don't see any other questions. I have one last question, and just how, like, I remember reading a few years ago an article on like depression is not defined as a chemical imbalance anymore, but there's something else going on. I don't remember if it was in addition to that or aside from that. So can you clarify like how depression in our body, like, is that a chemical imbalance or is there something else going on?
At its basics, I guess it is more of a hormone imbalance, but or I guess if you call a hormone a chemical, then yes, it is. But it's a lot of other things with it, like how you adapt to it, how like what situations are placed, what situations you're placed in, like what type of environment you're in. All of those things can change how you perceive like your feelings and emotions and how you deal with them and that kind of stuff. And all of those things come together to form a diagnosis of depression. It's not only at its roots like a hormone imbalance. It's a lot of things together. It's a very complicated diagnosis.
Mm-hmm. Okay. Okay. And sorry, I thought that was my last question. One last question. When some people can be like medication resistant when
Mhm.
treating depression, right? And yeah,
Yeah.
and can you just a little bit explain that?
Yeah, so there are a lot of different medications we can use for depression and anxiety and a lot of other mental health diagnoses, but I'll just stick with depression and anxiety. So the first thing we usually try is what most people respond to, and most people just means greater than 50% of people. And there is a subset of people that have to go to the next step, and all of these different steps work slightly differently to increase the level of different types of hormones in your body, because depression can like decrease, for example, serotonin. It can decrease, for example, like norepinephrine and all of these different hormones in your body. And so the uh, the medication that works for a particular person can be different, and in different parts of their life it can be a different medication as well. And so we go through a kind of tiered method. We start with the one that works for most people, and then we have a lot of different options down the line. And kind of the treatment resistant depression people, we try a different route. It's not like there are no medications left for them. It's just that we try a medication that's not necessarily what we would first jump to.
Thank you for answering. With that, we'll close it out. It's exactly 501. Yep. Oh, someone's just joining us. I think they got kicked out, and so yeah. No, I want to say thank you so much, everyone, for joining us today, even with the time change, and our doctors for being here. We will, I think this topic actually came from the members. They voted to have mental illness in children and teens. So yeah, we will, I will communicate with Dr. Abram about our next topic and then go from there. Thank you so much, doctors, for your presentation. Very informative as always. Yeah.
Thank you.
Thank you.
And thank you everyone for joining us. Have a good night.
Bye.
Bye.